Hello, I am Sophie Brisker. I will be discussing disparities in OBGYN care in disabled women compared to non-disabled women. First, we will start by defining key terms like OBGYN and categories of disability. What is OBGYN? OBGYN is the combined specialty of obstetrics and gynecology. According to the Merriam-Webster Dictionary, obstetrics is the branch of medical science that deals with pregnancy, childbirth, and the postpartum period. Obstetric patients are of reproductive age. The Centers for Disease Control and Prevention, or CDC, as I will refer to it from now on, defines it as ages 15 to 49. Merriam-Webster Dictionary defines gynecology as a branch of medicine that deals with the disease and routine physical care of the reproductive system of women. This care can be utilized throughout life. Many studies divide disability into 4 categories. Physical, which usually involves difficulty with ambulating. Sensory, where there is difficulty with hearing and/or sight. Intellectual, which is often defined via intelligence quotient testing, also known as IQ testing, and cognitive, where the person has difficulty with memory, thinking, and performing complex mental tasks. As you can see in this infographic, disability is more common in Black Americans than white Americans, and those Black Americans are more likely to smoke and be obese. The healthcare inequities faced by Black Americans are exacerbated by disability status and vice versa. A key part of obstetrics is prenatal care. Like many other areas of this branch of medicine, disabled women do not receive equitable prenatal care, which increases their risk for adverse outcomes during birth and pregnancy. When it comes to disparities in prenatal care, women with sensory or intellectual disabilities are most affected. Women with these disabilities were less likely to get the minimum number of prenatal visits and less likely to start prenatal care in the first trimester compared to women without disabilities. Women with intellectual disabilities were the most affected, with 4.5% of study participants beginning care in their third trimester. Interestingly, women with physical disabilities were more likely to have over the number of minimum prenatal visits and more likely to begin prenatal care in the first trimester when compared to non-disabled women. Disabled women are at higher risk for all types of pregnancy complications. According to Gleason et al., the composite risk of any type of pregnancy complication was highest in women with spinal cord-related disabilities, with an increased chance of 53% compared to non-disabled women. Women with intellectual disabilities were not far behind, with a 49% higher risk of pregnancy complications than women without disabilities. Women with physical disabilities also had a significantly higher risk of complications, 27% higher than able-bodied women. Here are some of the complications disabled women experience that may contribute to the composite risk previously discussed. They are gestational diabetes and/or hypertension, infection, postpartum depression, endometritis, and thromboembolic disease. Disabled women are also more likely to have risk factors for the following compared to non-disabled women: hemorrhage, chronic hypertensive disease, and peripartum stroke. Disabled women experience more planned deliveries, operative vaginal deliveries, and a higher rate of oxytocin augmentation during labor. In addition, disabled women were found to have double the risk of severe preeclampsia and eclampsia compared to women without disabilities by Gleason et al. Looking at specific types of disabilities, women with intellectual and physical disabilities have been identified as having a higher risk of certain complications. According to Signore et al., women with intellectual disabilities had a threefold higher risk of pulmonary edema and/or venous thromboembolism during pregnancy, and an increased risk of peripartum hemorrhage and abruptio placentae. Also, according to Signore et al., women with spinal cord-related disabilities are at a 9-fold increased risk of pulmonary embolism and/or venous thromboembolism. Women with physical disabilities are twice as likely to have a miscarriage, according to Darlian et al., and a higher risk of preterm birth. Women with 2 or more physical disabilities or a physical disability with a comorbid mental illness were at an even higher risk for preterm birth compared to their non-disabled counterparts. Disabled women are more likely to be hospitalized for non-delivery reasons during pregnancy and stay in the hospital much longer after delivery. Women with physical disabilities are 1.4 to 1.9 times more likely to visit either the emergency room, known as the ER, or be hospitalized during pregnancy compared to women without disabilities. Women with more than one physical disability were 3.6 times more likely to have an inpatient hospital visit and 2.8 times more likely to visit the ER than non-disabled women. Women with physical disability and a comorbid mental illness were at a slightly lower but still high risk. These women were 3.3 times more likely to be hospitalized and 2.6 times more likely to visit the ER compared to women without disabilities. Post-delivery hospitalization stays were longer for women with any disability. These stays could be anywhere from 2 to 14 days in women with physical, spinal cord-related, or self-reported disabilities. Women with 2 or more physical disabilities or a physical disability with a comorbid mental illness were 3 times more likely to be hospitalized for greater than 5 days post-delivery compared to non-disabled women. Cesarean delivery is used more often in disabled women than non-disabled women. Women with physical disabilities are twice as likely to deliver via C-section. Reason for these C-sections are gestational hypertension, fetal anomaly, danger to the fetus, and other /unknown. Also, disabled women have an overall higher risk of maternal mortality. C-sections make subsequent deliveries more dangerous, according to a book by Dr. Harvey E. Kurowski, and more likely to lead to another C-section. It increases the chance of invasive placental disease due to uterine scarring, which can cause massive bleeding during placental removal and usually requires a subsequent hysterectomy. Though these complications are rare, doctors usually opt for another C-section rather than risk vaginal delivery, creating more scar tissue. Provider-patient relationships are extremely important in care. The problems between disabled women and their providers have substantial impact on their overall health and medical care. Despite the importance of communication, it is often inadequate between providers and the disabled patients. Deaf and hard of hearing patients have reported preferring American Sign Language, or ASL, interpreters, but doctors often do not have them available and use communication modalities like lip reading and writing notes. Since only 30 to 40% of spoken English is understandable through lip reading, this is especially problematic. For women with vision difficulties, Braille is often unavailable and large fonts are sometimes utilized. However, commercial print materials and information on conditions are unlikely to be in Braille and not always available in large print. For intellectually disabled patients, providers report communicating with caregivers because they are unsure of the patient's ability to communicate. Pregnancy prevention is considered very important to providers in women with intellectual disability because of erroneous beliefs about their parenting abilities. However, in women with other disabilities, it is often not discussed due to the misconception that disabled women do not have sex. Sexually transmitted infection, or STI, prevention is usually not discussed. Contraception is only discussed in the context of managing menstruation. For women with physical disabilities, maneuvering in the office and exam rooms, getting dressed or undressed, and transferring to and from the exam table are all additional challenges. Lastly, providers are often ignorant of the existence of guidelines for treating patients with disabilities. Disabled women are less likely to be screened for cervical cancer, but women with intellectual disabilities are at the highest risk. Women with physical disabilities are less likely to have pap smears that test for abnormal cervical cells because of the pain and discomfort they may experience. This may make it more difficult for the provider to perform the procedure, especially if pain management is not considered. The lack of communication between women with intellectual disabilities and possibly the patient not understanding the procedure has led to providers foregoing mammograms and pap smears. STI screening is done less in disabled women also, but for a different reason. Many providers do not think it is necessary since they assume their disabled patients are not sexually active. Women with intellectual disabilities are 72% less likely to be screened for cervical cancer and 45% less likely to be screened for breast cancer, according to Agaronics et al.'s Ensuring the Reproductive Rights of Women with Intellectual Disability. As you can see in this infographic, early diagnosis is crucial in surviving cervical cancer. Since screening specifically for cervical cancer is foregone so often in women with intellectual disabilities, they are more likely to end up in the 84% of women who do not survive 5 years after being diagnosed because they were diagnosed in the advanced stage. Sexually transmitted infections, or STIs, are more common among disabled women than their able-bodied counterparts. According to Parekh et al., disabled women are also at higher risk for other factors that elevate chances of contracting an STI. These factors are being sexually assaulted or abused, having condomless intercourse frequently, and poverty. Untreated STIs can lead to pelvic inflammatory disease, adverse neonatal outcomes, higher risk of HIV, and ectopic pregnancy. This is a bar graph showing the prevalence of STIs among women with different types of disabilities or none per year over the course of the years 2015 to 2019. As you see, disability is associated with increased prevalence of STIs. Though comparison varies between individual years, overall, women with cognitive disabilities had the highest rate of infection at approximately 6.9% per year. Women with 2 or more disabilities had the second highest infection rate, with an average of 6.6% STI prevalence per year. Women with sensory disabilities had an elevated risk as well, with a yearly infection rate of 4.44%. Women with physical disabilities had the lowest infection rate among disabled women, but still higher than their non-disabled counterparts. Women with physical disabilities had an infection rate of 3.02% per year, and non-disabled women had an infection rate of 2.68% per year. Contraception is one of 2 ways of preventing pregnancy, the other being abstinence. There are many types of contraception. Medical contraception includes intrauterine devices, or IUDs, pills, and sterilization. Disabled women are less likely to use contraception than non-disabled women. Mosher et al. Found that 14.1% of disabled women did not use contraception compared to 9.5% of non-disabled women. Women with cognitive disabilities used contraception the least, with 16.9% of these women not using contraception. Intrauterine devices, or IUDs, are used the least by disabled women. Female sterilization is the most common method of contraception in the United States among both disabled and non-disabled women. According to the CDC, 18.1% of women from ages 15 to 49 use female sterilization for contraception. This rate is higher among disabled women, with 30.2% of disabled women using it to prevent pregnancy. The United States has a long history of sterilizing those considered undesirable. Among those have been disabled people. Intellectually disabled people have been targeted the most and continue to be forcibly sterilized in most of the country to this day. Legally, according to Chamwell v. Amerisher Mutual Insurance Company, intellectually disabled is equivalent to feeble-minded. Epileptics were also targeted, though it is unclear if it is referring to the neurological condition we know today as epilepsy. According to the Indiana Historical Bureau, the first law that set a process for legally forcibly sterilizing feeble-minded wards of the state was passed in 1901 by the Indiana legislature. In 1907, the state of Indiana made sterilization mandatory for, quote, criminals, idiots, rapists, and imbeciles in state custody, unquote. The governor of Indiana put a moratorium on these laws in 1909. Then, in 1921, the Supreme Court of Indiana declared the involuntary sterilization laws unconstitutional. These laws were created to prevent people from having children and passing on traits they believed to be hereditary. Once the Supreme Court of Indiana had deemed the involuntary sterilization laws unconstitutional, this opened other sterilization laws up to legal challenges. Then, in 1924, Virginia passed a law legalizing the sterilization of those the court deemed feeble-minded, insane, or epileptic. Carrie Buck became a ward of the state and then was sent to the Virginia Colony for Epileptics and Feeble-Minded, where her mother was, the same year the law was passed. The superintendent of the colony decided Buck needed to be sterilized and used her case to establish the constitutionality of the law so that it would not be stricken down like Indiana's. Buck tried to get the court to stop her sterilization. The case went all the way to the United States Supreme Court, where the justices deemed the law did not violate the Constitution. This allowed new laws to be passed without fear of legal challenge. Buck v. Bell, the name of the court case, has no direct challenge and remains a precedent used to this day. Though sterilizations are often done under conservatorship or guardianship, it is still allowed. The court goes through the process of declaring someone mentally incompetent and then determines whether it is in their best interest to be sterilized or not. The patient's preference is not considered. As of 2022, 22 states and the District of Columbia have laws allowing involuntary sterilization. Alaska and North Carolina are the only states that have laws that ban the practice. 9 states have local legal precedents that allow the practice. 17 states and 3 territories have no law or local precedents regarding the practice. The states in dark purple allow forced sterilization. The states in light purple have no laws about it, and the states in turquoise have banned forced sterilization. Thank you for watching. Here are the resources used for this presentation.